Just thanks for your patience, guys. Okay, so we'll officially get started. It's great to see you guys. Thanks so much. I see a lot of new faces out there, so welcome to One Health Academy, and as well as some familiar ones. So thanks everyone for coming, and we're excited to get started after our summer break. I'll try to keep this short so we start on time. But for those of you that don't know me, I'm Blair Budd, and I'll be taking Will's place in transition of leadership for this upcoming year. Though I'm sure you're aware, it's sad to say our previous director, Will Sanders, moved from DC to Central Illinois to take a position as assistant professor for preventative medicine and public health at the University of Illinois College of Veterinary Medicine. So we're really excited for him, and I'm sure he's going to do awesome things there for One Health. So congrats to Will, and I look forward to meeting more of you on our journey together, and I'm excited for this opportunity. So thanks so much for coming. And before I introduce Dr. Lucey, a quick few notes, some housekeeping. Bathrooms around the corner in the lobby, straight back to your right. Make sure to help yourself to some food and drinks. And please see Sarah if you haven't already, right there in the corner for sign-in and payment. Thanks for everyone who's already taken care of that. And in addition, One Health Academy is currently looking for volunteers to join our team. So I just especially want to thank Jill Sutton in the back there for joining on as our new social media specialist. And please see me after if you're interested in volunteering and helping out take a position. So thanks for that consideration. And then next month we'll be starting our annual survey. So we'll be sending that out to the listserv. Thanks in advance for your patience. And I know that we've gone through a lot of changes in the last couple of months, minus the summer break. So we're always open to your feedback and, want to continuously improve. So if you get a chance, please take the survey. And then, as always, thank you to the One Health Commission for sponsoring our webinar capabilities. I know many of you online right now are able to see this and partake in our seminar because of the One Health Commission, so we could not do that without them, and ask that you consider supporting them if possible in the future, as well as the American Society for Microbiology with Mark in the back. Thank you so much for hosting us and allowing us this opportunity to have a place to commune and talk about One Health. Are there any announcements that you'd like to make, Mark, before I move on? Cool, awesome. Awesome. Okay. Tonight, thank you so much, Dr. Lucey, for coming. I have the honor to present you. This will be Dr. Dan Lucey's third time presenting at the One Health Academy. So we are especially grateful for his continued generosity and sharing time with our One Health community. And this is a long list, so I'm going to make it really quick. Dr. Lucey is an infectious disease physician who travels to epidemics like SARS, MERS, influenza, anthrax, Ebola, Zika, and yellow fever. He is a senior scholar with the O'Neill Institute for National and Global Health Law and an adjunct professor of microbiology and immunology at Georgetown University Medical Center. He represents JUMC on the One Health Commission Board of Directors. And as a physician trained at Harvard in infectious diseases and public health, he has taught for many years, co-founding a graduate program on emerging infectious diseases and biohazardous threat agents at JUMC. He has worked in U.S. Public Health Service and at the National Institute of Health, traveling widely in Asia, Africa, and the Middle East to exchange information regarding zoonotic infectious diseases. And if that was enough, he is the author of over 100 papers and book chapters. So it is truly an honor to have you yet again here with us tonight. Please join me in welcoming Dr. Daniel Lucey.
Thank you very much, Blair.
One more guest.
Okay, yes, please, one more guest. Go right ahead, sir.
My name is Cheryl Cahan, and I am now a livestock advisor at USAID in the Bureau for Food Security.
Welcome. Thank you very much for that kind introduction, Blair, and thank you everyone for coming out tonight, and thank you, Mark and American Society of Microbiology, for allowing the Academy to have the meeting here again. And for your support of the exhibit. For those who can see, there are, I think, about 8 or 9 panels from the do-it-yourself DIY version of the exhibit here in the lobby of ASM, 2 of which Blair and I brought into the room. So I have about 25 slides, and I'd like to talk for about 30 or 35 minutes and then leave time for questions, and then we'll be completely done by 8 o'clock. It's about 7:05, 7:04 now. And I'm glad to stay after 8 o'clock for anyone else who would like to stay and chat a little bit more. The exhibit, I hope most of you have gone to see it. It opened on May the 18th of this year, 2018. It's scheduled to be open for at least 3 years. The title is Outbreak, Epidemics in a Connected World, and the connection is One Health. And in the presentation tonight, this is the synopsis of it. I would like to focus on One Health, which is most of the exhibit, certainly the first 2/3 or so in particular. I'd like to start by thanking the many people who really create the synergies of strength. By synergy of strength, I mean all of you, people that supported and contributed intellectually and in every other way to make the exhibit become a reality in the museum, and also the do-it-yourself print-on-demand version that can be obtained by anyone in this room, for example, by contacting the museum, Miss Carrie Dean, and you can see her email address here on the right-hand side of this slide. Simply your last name, Dean, and then K at SI for smithsonianinstitution.edu. I would specifically like to thank Dr. Cheryl Stroud from the One Health Commission based in North Carolina for making this webinar possible and for archiving it and therefore saving it, making it available for people who can't watch it this evening or in the near future. I'd like to speak primarily about what's inside the museum in terms of the exhibit. I'd like to emphasize first and foremost that the curator for this exhibit is a tenured anthropologist at the National Museum of Natural History, or the full Dr. Sabrina Sholts. It's been a real pleasure working with her.
I'm having a few audio issues. Sorry, guys.
Oh, sorry. Online?
But they can't hear.
Oh, they can't hear.
What's going on? But feel free to continue. Audio.
This might be my most important slide, to give credit where credit's due.
Oh,
So I'm dismayed if people online can't hear it. They'll say, oh, he didn't thank us. Maybe they can see the slide, though.
Yeah.
I think you need to click start.
Thank you. Thought I hit that beforehand. All right.
Slides won't move.
Oh, of course.
Sorry.
What's going on? Let me click on this. There you go.
Yep.
Okay.
Thank you. Okay. To summarize briefly, the exhibit opened on May 18th of this year, and it's going to stay open for 3 years at the Smithsonian Institution National Museum of Natural History. I'd like to start by thanking some of the many people that have worked together as a synergy of strengths with their various expertise to make the exhibit a reality. So first of all, I'd like to thank Dr. Cheryl Stroud of the One Health Commission in North Carolina, who's made this webinar possible and also has assured us that it will be archived and therefore available for your listening pleasure in the future. I'd like to talk about what's inside the museum as well as what's outside the museum. What's inside the museum is what the focus of tonight's talk will be on, particularly the One Health aspects of the exhibit, which is, as you'll see, the central part of the exhibit. The curator is Dr. Sabrina Sholts, who's a Ph.D. tenured anthropologist at the National Museum of Natural History. We didn't meet before the exhibit, but it's been a great pleasure and honor working with her for the last 4 years. This is really 4 years and 1 month ago, on August 7th, 2014, that I first came to the museum, thanks to a student of mine in Georgetown, arranged the meeting and proposed the exhibit. That was about 2 days before I got on the plane to make the first of 4 trips to work in West Africa during the Ebola outbreak. In addition, inside the museum, there are multiple, meaning 60 or more volunteers who have a wide spectrum of expertise, and they are always there 7 days a week, volunteering to help visitors go through the exhibit. And some of you, as you mentioned, are among those volunteers already. And there's openings for more in the coming year, in the second year. They're trained by Dr. Ashley Perry, who's supported by the American Society of Microbiology with the Museum of Natural History, working under Robert Costello and Barbara Stauffer as part of the education team at the museum, the National Museum of Natural History. Outside the museum, I'll speak briefly and show some pictures at the end with regard to what's called we call the do-it-yourself DIY print-on-demand version of the exhibit. So anyone, including any of you in this room, can email Carrie Dean at the museum. Email is shown here, deankay@si.edu, and request the paperwork, which is really straightforward, to be able to get a Dropbox with all the information that you can access to make your own version of the exhibit. For example, print out banners like what you see here at the front of the room that are on display here in the ASM. In addition, very soon, if not today already, you'll be able to access the interactive videos and a interactive game that helps you to identify a disease X by working together with veterinarians, physicians, epidemiologists, and laboratorians. It's been very exciting to see that this DIY version has been, the paperwork has been signed with over 40 partners in the United States and multiple countries in South America, in Asia, in Africa, in Europe. And it's been translated already into French, Spanish, Chinese, Arabic, and several other languages, with more planned. This is from the beginning when you first walk into the exhibit, and I just show briefly. On the left is a spectrum in alphabetical order of organizations that contributed their expertise, and you'll see ASM is first. And on the right-hand side, you see, so it's your left-hand side, sorry, my right-hand side, spectrum of major donors. It's really quite a distinguished list, and without the donations, obviously, we wouldn't have been able to go forward. Again, Dr. Sabrina Sholts is the curator. This is a picture of her with a skeleton because she's a physical anthropologist by training and an expert on environmental toxins and on microorganisms from teeth in fossils. I hope that's the right word, sorry. And the writer for the exhibit, for the entire exhibit, everything that you read there was written by Angela Roberts, which is very, very important. I think it's a wonderful, wonderful exhibit, both the visual aspects, whom I'll credit in the next slide, and the words. The entire exhibit, it's much greater than what I could even imagine. So for me, I'm basically a person that just thinks in terms of words. So I said, well, it'd be great to have an exhibit on epidemics. Okay, so that's pretty much my contribution. Okay. This is a picture from the opening. It's a little hard to see. Sabrina took it, put it on Twitter, and I don't do Twitter, so I just cut and pasted it, and it's what it is. So from your left to the right and going across is partners, part of the Smithsonian team that made the exhibit possible. So Sally Love is shown here with Robert Costello, Meg Rivers, Sabrina Sholts, Shannon Willis, and Julia Louie. Julia and Shannon are the visual designers. John Epstein and myself are non-full-time Smithsonian members of the team. And I'll talk more about John in just a minute and show some more pictures. Not pictured, but integral to the team are Suzan Murray from the Smithsonian National Zoo and Global Health team, and folks who work for her, Don Zimmerman, Megan Vodzak, and then back at the museum, Junko Sheenan and Mike Lawrence, who's an architect by training, and many others. What you see up here on the wall is, you also see on this slide, and it's to recognize the many people. There are about 30 pictured here, but there are 42 total from around the world who we asked to offer personal perspective about their involvement with specific epidemics. When Angela Roberts, the writer, said to me, Dan, do you know some friends around the world you worked with in these various epidemics that would like to offer a personal perspective? I said, oh, yes, I know some people. She says, okay, why don't you talk to them, have them send a picture and send a personal perspective in writing, but it has to be less than 100 words. I said, oh, nobody can do it in under 100 words, and especially not me. She says, well, I'm not talking about you, but she says, why don't you just ask them, and if they can't do it, fine, we'll ask somebody else. So I asked 30 people, pictured here, 30 people all said yes. And not a single one said, oh no, I can't do it in under 100 words. Everybody said, fine, what are the rules of engagement? Under 100 words, picture, and they sent it in right away. So it's very, very gratifying. So some of the people here you'll recognize, some of whom I'll show from when their personal perspective and their picture is on display in the exhibit. But for me, it's been very meaningful to be able to have worked for many years with colleagues in this country and overseas, and to have them be able to offer their personal perspective in the exhibit in the museum. So here we are at the entrance to the exhibit. So let me just ask, how many people here have been to the exhibit? Roughly half, okay. So I won't assume that everybody's been there. So this is the entrance to the exhibition. And what is there now, although this particular sign says One Health in 90 seconds, that wasn't there in the very opening, the first month, but it's been added because we thought it would be helpful. So what is there is the sign says One Health in 90 seconds. There's a video that runs for just 90 seconds, and it basically summarizes the entire exhibit, of which there are about 9 or 10 sections. And it takes hours and hours, or in my case, days and days to go through it, to read everything. And so again, what I'm going to show tonight is just really just a summary focused on the One Health aspects. There's a quote from Billy Karish, whom probably most of you know, that's in the exhibit in the beginning, from way back in 2003. He says, human or livestock or wildlife health can't be discussed in isolation anymore. There is just one health. And I think probably everyone in this room would agree. The video includes simultaneous stories, visual stories, and there's a voice story also for about 6 different panels. And I strongly encourage you to see it once or twice or 3 times. For me, it's very, very powerful. And it really makes a strong visual case for why One Health is important in epidemics. Section 1 is called One World, One Health. And as you can see in one of the 2 slides here, the One Health concept, we explicitly focus on human health, animal health, and environmental health. And why One Health? Again, at the beginning, we have this statement that is, and I'll read it, by understanding how these activities and others drive the emergence and spread of disease, we are able to make changes for a healthier world. So we show a couple examples. I'm going to cite 4 of them very quickly here. Again, this is from the first section of the exhibit. The question is, how do humans drive disease emergence? One example we give is animal trade, and we use the case of monkeypox that was brought to this country in 2003 from West Africa through exotic pet importation. And then, unbeknownst to anyone, prairie dogs were susceptible to monkeypox. And then some people over 30 got infected. Fortunately, none died, although some were very ill. Another example is urbanization. Here we use the case study of Ebola. We'll talk about that a little bit more in a few minutes. Obviously, the Democratic Republic of Congo, DRC, is having their 10th outbreak of Ebola, 10th recognized outbreak, I should say, since 1976, when it was first discovered in Yambuco in DRC, then called Zaire. And it's reached a city of several 100,000 people, Beni, and also a city just of about 1 million people, Butembo, just in the past week. 2 other examples of humans driving disease emergence are global travel, which we're familiar with a lot of examples, but the one that we emphasize is SARS. We also talk about MERS, but that can apply to many, many diseases. Obviously, during Ebola, in 2014-15, West Africa, there was international travel that ended up having patients with Ebola in this country as well as Europe and other countries in Africa than where it started. And finally, industrial food production. And the example there that we use is avian influenza, avian flu, both H5N1 and the more recent H7N9, which so far, to the best of our knowledge, is still confined to China, both in animals and in people. Personally, I don't think that will last much longer. I think it's going to spread beyond China. In terms of outbreaks and One Health perspectives, one thing that we emphasize is shown on these slides. Wildlife and pathogens are not out to get us. We are intruding on their territory. And on the other slide shown, you can see that we emphasize that humans can give diseases to other animals. It's not strictly a one-way transmission of pathogens. And an example that's cited here is measles, which can be fatal in chimpanzees and gorillas. The second section of the exhibit we call Spillover and Outbreaks. And here we have 3 examples of viruses. We focus on one as a main example, and that's Nipah virus. We also talk about hantavirus nombre from the United States, so summer of '93. The Four Corners, Utah, Colorado, Arizona, and New Mexico. And then more recently in Yosemite. And then there was a report recently of a patient in New York. But obviously it's occurred in multiple other states as well as in Central and South America. And on the other slide that you see here is a picture from his work in Bangladesh of Dr. John Epstein, whom probably most of you know from EcoHealth Alliance, veterinary disease ecologist, who spent, I think, at least a decade in Malaysia and Bangladesh and India and elsewhere studying bats and Nipah virus. As you probably know, in Malaysia, the animal linked to the outbreak, the first outbreak of Nipah in 1998 that was recognized, probably there was one in '97, but it wasn't recognized, involved pigs and bats and mangoes. So fruit bats eating mangoes, spreading the virus through saliva or urine, which then bats were exposed to and infected, and then they infected people. But in Bangladesh, there are very few pigs. And so the outbreaks of Nipah there have involved date palm sap, which the bats like to drink. And when they urinate with the Nipah virus into the collection pots, then people drink the sap, not knowing there's Nipah virus there, and they get sick. And what's happened in Bangladesh is that a small percentage of humans transmit the virus to other humans. And that wasn't recognized to have happened in Malaysia. So the epidemiology has changed. The sequences are different, the strains are different, but we haven't been able to identify the exact genetic link or cause for the human-to-human transmission that occurs in Bangladesh and in adjacent parts of India. And as you know, in May of this year, for the first time ever, Nipah was found in Kerala in southwest India, more than 1,500 kilometers away from parts of India that are adjacent to Bangladesh, where there's been outbreaks of Nipah. The third section is called International Spread of Diseases. And again, we could have many examples, but the main one that we choose is SARS. And then the smaller example that we choose is MERS. The example of SARS obviously involved the animal was civets, and MERS, it's clearly camels. But as you can see in the slide here, there are a number of animals that I've mentioned already, some like pigs associated with Nipah, chickens and bird flu, camels and MERS, mass pump civets, and SARS. On the other side is a picture of personal perspective by Dr. David L. Heyman, who's an American, worked for many years in Africa, then for CDC, then at WHO, more recently in London since around February 2009. David led the WHO Geneva headquarters response from the WHO in Geneva that successfully stopped the SARS epidemic within 6 months of it being declared or recognized, all in 2003, between about February and July 5th of 2003. So throughout the exhibit, we have this symbol. You can see the two up yellow arrows. It's called on the upside. So we try to emphasize some positive aspects about responding to or preparing for or stopping. In this case, this is a big up, stopping SARS, and it hasn't come back. So that is a tremendous success, which we can't really say, to my knowledge, has occurred very often since then with regard to other epidemics. So MERS, avian influenza, Ebola, Zika, etc. So it was really a wonderful international effort that was coordinated by the Director General of WHO at the time, Glo Brundtland, but I would say that David Heyman was really the person who worked, the 20-hour days for many months to coordinate the international response to stop SARS. The next section is called Global Pandemics, and here we're aware that sometimes there's a debate about what's a pandemic. Personally, I like the word pan-epidemic because I think it kind of bridges the outbreak to epidemic to pandemic, but it's just a word I made up, so it didn't make it into the exhibit, alas. So global pandemics, we chose the two that no one's going to argue about, right? Well, I argue about everything, but really there's no argument to be made. It's HIV and pandemic influenza. And the one they emphasize as the big example is HIV. But certainly it's the 100-year centenary, if you will, or the centenary of pandemic influenza of 1918, which really went on into 1919 and possibly 1920. And then there's been other pandemics in 57, 58, 68, and then 2009, 2010 that you all are aware of. The next section is called Responding to Outbreaks. And here, probably because I was on the committee, because I was there, I felt strongly that of all responding to outbreaks, we could talk about any and all of those, and pretty much all the outbreaks or epidemics in the exhibit in the museum are ones that I've gotten to, so I could speak and show pictures and talk about friends to contribute. But the one that we chose for responding to outbreaks, the example we chose was Ebola in West Africa. We talked about Guinea, Sierra Leone, Liberia, but then at the same time, in contrast, we talked about the Ebola outbreak in Nigeria that went on at the same time that was successfully stopped. As it was in Senegal, there's only one case, and in Mali. But I think personally, in fairness, there are a number of reasons why the outbreak was stopped that are very admirable, and that's quite factual, why it was stopped in Nigeria and Senegal and Mali. But I think that chronologically, it's very important to recognize that the outbreaks there began after the outbreak in Guinea, Sierra Leone, and Liberia. After the virus had been identified, and around March 22nd of 2014 in a lab in France from blood of several patients with an unknown disease in Guinea. So the lab diagnosis had to be made in a different continent. So that's also a fact that I think is very important, and personally, I hope that never has to happen again, that the laboratory diagnosis be made in country or certainly in region where the outbreak occurs. And that certainly has occurred with Ebola in the DRC last year and both times this year, with the diagnosis being made in Kinshasa and DRC. One thing that we really emphasize about the responding to the outbreaks to stop Ebola is the central role of the community. And you'll see that again today in this outbreak, the ongoing outbreak, including the information today that came out from the DRC Ministry of Health. They put out an update on the Ebola outbreak in North Kivu and Ituri province every day. It's in French, it's short, it gives numbers, but also it gives a short dialogue about what's going on. And predictably, everyone thought this could happen. It has happened. Hopefully it won't get worse. It happened in 2014-15 where there's what's called community resistance. With regard to, I don't quite know how to best say this, but I think the community doesn't understand the cause or the nature of the epidemic and what needs to be done to stop it, including making major changes in traditional practices, for example, traditional burials. But it's absolutely crucial that there's an anthropological and sociological approach that's successful approach to working with the affected communities and outbreaks, epidemics in general, but Ebola, Marburg, I'd say even Nipah and others that involve person-to-person transmission and when there's transmission at burials, for example. It's essential to be able to stop the epidemic, and that could make things much more difficult to stop the ongoing outbreak in the DRC. Specifically, if then the virus spreads in one or more cities where it's now gotten to, but in very small numbers of patients, and then if it spreads across to Uganda or South Sudan or Tanzania or Rwanda or elsewhere. This is a slide of from the Ebola epidemic in 2014 in Liberia. It has great personal significance to me, which is why I'm showing it. There's a picture of someone I worked with, Jackson Naimah, who's a physician assistant, Liberian physician assistant. His wife's a nurse who works at JFK Hospital in Monrovia, the capital. Both of them worked throughout the entire Ebola epidemic in Monrovia. There's a picture of Jackson that he submitted with his personal perspective, talking about delivering a baby from mom who is pregnant, who had Ebola in one of the tents where we worked together in the first week of October in 2014. There's an aerial view of the MSF Ebola Treatment Center on the other side of this slide, which was initially opened in mid-August 2014, was able to at first provide care for about 40 patients. It was immediately overwhelmed, and they expanded it to 80. It was overwhelmed, they expanded it to 120, they expanded it to 180. It's the largest Ebola treatment center that MSF, Doctors Without Borders, Médecins Sans Frontières, MSF has ever built. And I think it's the largest that's ever been built, and I hope it's the largest that ever needs to be built. So Jackson and I worked there for 6 weeks. By sheer coincidence, a month before Jackson and I met, or about 3 weeks before, he was the person that you can find online who spoke directly to the United Nations Security Council about Ebola, running his MSF Fest by video connection from Monrovia. I'm not certain, but I think that was arranged by the U.S. ambassador to the United Nations at the time, Ambassador Samantha Power. Moving on to Zika, what's called now, as you know, is Zika Congenital Syndrome, formerly called microcephaly, which really just refers to the small size of the baby's head. But really, the issue was why is the baby's head so small? And it's because there's not nearly as much brain tissue there as there should be. And often the devastation is severe, and results in severe behavioral and developmental problems if the baby survives birth in the first few months. In the exhibit on one side of this slide, you see what to me is the scariest thing in the entire exhibit, although young kids, I don't know, younger than me. Okay, so young people, they love this. It's just massive, giant Aedes mosquito that you can see here, that's up on the ceiling of the exhibit or the roof. And it emphasizes that Aedes mosquitoes transmit Zika as they do multiple other diseases that we'll talk about at the end. The doctor that's shown here is Dr. Vanessa Vanderlinden, who's a pediatric neurologist in Northeast Brazil and Recife, Brazil. Her brother's a pediatric neurologist, her sister's a pediatric neurologist, her mother's a pediatric neurologist, and her father's a pediatric neurosurgeon. So you might imagine that they were among the first to recognize this epidemic of microcephaly, because Dr. Vanderlinden said, we invited her up from Brazil for a big conference, November 2016, on Zika at the museum, and she was good enough to come up with her brother. And she talked about how they saw in September of 2015, 3 children with microcephaly in 1 week. And then they, I guess, discussed it with their colleagues at the family table and the dinner table, but also among their other colleagues, and everyone was seeing the same thing. So whereas her mother said that, well, in her long career, she might see 2 or 3 patients like this a year. So now there's dozens a week. So for me, that's an epidemic, and it's real. Not everyone agreed with that at the time in early 2016 or late 2015. So for me, it was very important to get on a plane and go to Brazil and see for myself, and then be able to talk about it afterwards. And I never met Dr. Van der Linden, but I'd read some quotes that she gave to the New York Times. I said, she's a person that I want to meet. And so very fortunately for me, when I showed up in Recife, Brazil, and contacted her, she didn't call the police or anything. She just said, okay, I'll meet you outside the hospital tomorrow, and we'll see. But fortunately for me, then she allowed me to come in and see some of the patients and the parents, and then she showed me the brain scans of over 70 of her patients. And this is around February 9th or so of 2016. So I was convinced that there's an epidemic of microcephaly, and it was very likely due to Zika virus, which is what the Brazilian clinicians and researchers had already concluded. Section 6 is called Working Together. This is a very large section, and I'm just going to run through some pictures of people because that's what it's about, working together, synergy of strengths. It's what probably all of us have done and we all know we need to do to prepare better and respond better and recover better with regard to epidemics. So there is an interactive game that I mentioned originally. I had nothing to do with this. There was a company that was hired, and then Sabrina Sholts and John Epstein, someone from CDC, Meg and others worked to develop this game, which I think is really excellent. And so I encourage you to play it if you have the opportunity. And I think it's going to be available through the DIY version that you'll be able to access quite soon, meaning within a month. So the synergy of strengths requires a One Health collaboration. The quote that you can see here is, people with many different talents and skills fight against infectious diseases and for One Health. And again, here they have a veterinarian, epidemiologist, a laboratorian, and a human physician as team members. And you have to play the game at the same time in 3 different modules, if you will. And if you don't get it right, there's a narrator who comes on and she shows you what the epidemic curve looks like. Oh, and her voice, for me, it's like, whoa, it's very, you don't want to get it wrong. And if you get it wrong once, you don't want to get it wrong the second time, because she shows you what the results are in terms of the epidemic curve getting worse. So now I'd like to show a couple of pictures, a series of slides with a couple of pictures of people who you probably recognize. So on one side, I picture Dr. Dennis Carroll, USAID Emerging Pandemics Program Director. On the other side is Dr. Tony Fauci, a little bit younger time, 1980s, the National Institutes of Allergy and Infectious Disease Director, who really pioneered I think, the research in this country and funding in this country for HIV/AIDS from the very beginning. The next slide shows Dr. Cheryl Stroud from the One Health Commission and Dr. Jamechia Hoyle, who's the head of the Global Health Security Agenda, or GHSA Next Generation, which Taylor in the front row works with Jamechia as the deputy coordinator. And I think that both of them are going to be at the annual ministerial level Global Health Security Agenda meeting in November, 2 months from now, which is going to be held this year in Indonesia and Bali. And perhaps part of the exhibit will be shown there through the efforts of Jamechia and Taylor. And perhaps Taylor will present it, I learned tonight. So Cheryl is pictured here with her personal perspective, the 100 words or less, her perspective as the executive director of the One Health Commission. I think probably most of you, if not all of you, know the tremendous contributions for many years that Cheryl has made. She was a speaker here just June, before our summer break. She's been extremely supportive of the exhibit, came to the 3 stakeholder meetings that we had, and has been personally supportive to me in terms of being inviting me to be a board member of the One Health Commission. And to my knowledge, Georgetown is still the only medical school that has a board member on the One Health Commission. Hopefully that'll change if it hasn't already, but really my involvement is at least 50% due to Cheryl. And the next slide shows 2 very, very accomplished researchers who work on identifying the cause of outbreaks, as many people do, including some in this room. So on one side is Dr. Suzan Murray, who's the head of the Smithsonian National Zoo Global Health program. And this is a picture of her working in Kenya, I believe. More recently, she's worked in, her team's worked in Myanmar and elsewhere. And on the other side is Dr. Inger Damon, who's at the US CDC for many years after training in infectious disease at the NIH in the mid-90s. And she has what for me is the best title. If I could be reborn and be nearly as successful as Inger, which is not ever going to happen, then this I would like to have her title. So it's at the bottom of the slide, and it says Director of the Division of High Consequence Pathogens and Pathology, US CDC. That's what I always wanted to be.
Is that a picture of rhinovirus on the left?
Yes, from the original rhino, that's right. So just wrapping up here, One Health champions for decades, Dr. Larry Madoff and Dr. Olga Jonas, who turns out are friends since childhood in Massachusetts. Dr. Madoff, as you probably know, is the editor of the Program for Monitoring Emerging Diseases, ProMed, which is a central part of the exhibit. At the end, you can access the ProMed on some screens and just by touching any spot, any country in the world, and it tells you it's updated every day by ProMed. And then Dr. Olga Jonas, who for decades worked at the World Bank as the leading protagonist or champion for One Health, and just about a year or two ago retired and now works from the World Bank group and now works at the Harvard Global Health Institute. And later this month, they're having a Harvard Outbreak Epidemic Week from the 24th to the 28th of September. And Olga is one of the primary organizers of that, and they're going to have the do-it-yourself print-on-demand version of the exhibit there. So finishing up at the end, we always get the question, what's now and what's next? So when I give talks back at the old days in Georgetown, students were very nice, although, you know, I'm sure they were wondering, like, he's trying to kill us with all these PowerPoint slides. But finally, someone would say, like Jenny, like, this is very nice. Thank you very much for this nice talk about all these epidemics, all these pictures, these slides, and all these places you've gone. It's very nice, very nice, very nice. But what's next? And I understand that's really what's most important, what's next. And I actually believe that you can predict to some extent, but you'll always be surprised by the surprises, by what's, you know, unknown. And not predictable. But I think some things are predictable. And beyond guessing what's next, it's what are you going to do about it to try to either prevent it or mitigate it to make it less bad. I guess I only say the same thing, and I said that in the classroom, and I've said it, you know, when traveling overseas, and I say it when I give interviews, and I guess I said it about 20 or 30 times during the 3 years I was working with the team at the Smithsonian. And so I didn't ask them to put this up here, and it surprised me when they did, but then I shouldn't have been surprised. So what I say is what's next is already here. We just haven't recognized it yet. And that's what I really believe. The question is, what are you going to do about it? What are we going to do about it? So I'll just say what I think is next. And I've been saying this for 2.5 years, so it won't be surprised, really. But I don't think we've done what we need to do. And it's a huge obstacle to do that, but that doesn't mean that we shouldn't be not just trying, but succeeding. We have to succeed. Trying is not good enough when it comes to preparing and responding and recovering from epidemics. So I think it's going to be yellow fever epidemics. Since 2016, there's been a global vaccine shortage. That's my word. Others felt very strongly I shouldn't be using that word. I don't know, when you have to use 1/5 of a normal dose to vaccinate 7.5 million people in Kinshasa in August of 2016 for the first time ever anywhere in the world, to me, that's a shortage. But you can call it something else, a temporary inadequate amount. 1/5 is okay it protects people for a while, but the good news about yellow fever vaccine is it protects you for life. One shot, we used to say every 10 years. So I've gotten, I guess that's a lot of vaccines. I got like 6 shots of yellow fever vaccine. But now, as of 2016, WHO says officially, 1 shot of yellow fever vaccine protects you for life. So that's really good news. But unfortunately, since 2016, there's been a shortage. And it's not just Kinshasa in 2016, but earlier this year in Brazil, yellow fever epidemics, sylvatic, but coming up to right to the edge of big cities. And in Brazil, 1/5 dose of vaccine has been used this year in an effort to vaccinate 15 million people. The government is so, I think, appropriately concerned in Brazil that there'll be urban yellow fever outbreaks soon, and that hasn't happened since 1942 in Brazil, that they said a few months ago that the entire country, another 77 million people, have to be vaccinated against yellow fever. They didn't say 1/5 dose or full dose, but Brazil makes more yellow fever vaccine than any other country in the world. And there are only 4 manufacturers, and really just 2, Sanofi Pasteur in France and a company in Brazil that make a lot. The others are Russia and Senegal. So as you know, Aedes mosquitoes transmit not only Zika and chikungunya and dengue, but yellow fever. So I think that if urban yellow fever happens in cities in Brazil, and there's epidemics going on in Nigeria for the last 12 months, and then just last week it was announced in the Republic of Congo, Brazzaville, not DRC, there's a yellow fever epidemic. So vaccine is being given. In Nigeria, it's full dose vaccine. 25 million people are being vaccinated, starting last year and going into next year. So there's not enough yellow fever vaccine in the world now to give full dose vaccine, at least, where it's needed, where there are outbreaks occurring. So what would we do if there were outbreaks in other parts of the Americas or other parts of sub-Saharan Africa where it's always been the epicenters in the past? Yellow fever has never been recognized in Asia anywhere, and yet Aedes are there transmitting dengue, Zika, chikungunya. I think that it'll happen eventually. Yellow fever will go to Asia, and eventually might mean next year. Especially if there's outbreaks in cities where there's international airports in Latin America, Brazil, or sub-Saharan Africa. So I think we need to make a lot more vaccine. So in closing, it's already 7:45. This is a slide, information that public information that Dr. Ashley Perry, who's the public outreach fellow from the American Society for Microbiology and also the outbreak educator for the Smithsonian Museum of Natural History. And she says that just from May to July, so not even the past 5 weeks, the outbreak team has given tours of the exhibit to 22 organizations. And I can say, honestly, there's at least another 22 approximately. So it's really gratifying to see the interest in the exhibit among colleagues like yourself and others. And in addition, the do-it-yourself version, there's been approximately 100 requests for it to Carrie Dean at the museum. And again, there's her email address, deancarrie@si.edu. 42 have already signed the paperwork, and they are from multiple states in our country, but also in the Americas, multiple places in Asia and Africa, and in Europe. And so I think that there'll be even more, in the coming months and years. In addition, there's public workshops on outbreaks. For example, Ebola, avian influenza. There's one coming up on September 26th in the evening, 6:45 to 8:45 at the Museum of Natural History. So anyone who's interested, I encourage you to go ahead and sign up and participate. And this is the last slide. Again, I'd like to thank you, ask for any questions and comments, and again, emphasize that what I mean by synergy of strengths is all of us, all of them in this picture, these 4 people that from your right is John Epstein from EcoHealth Alliance, Sabrina Sholts, the curator of the exhibit, Robert Costello, who's overall museum lead for educational outreach, including into schools in DC, as well as in the United States, as well as other places, and then myself. And what I did on the opening night, but not for tonight, was I got flags from all of the countries that outbreaks have occurred in that we're highlighting in the exhibit. And then I arranged them according to the outbreak. And I don't know, my kids said, "Dad, really, you gotta retire, you're losing it." But it made me happy. So here I'd like to stop and take questions. So thank you.
Thank you so much, Dr. Lucey. I'm going to pass the mic around, and if you wouldn't mind repeating it just so the video catches.
Thank you very much. I've worked at WHO and I know a number of the people, so this is a very, very important discussion, and I really appreciate your promoting the need for people to understand linkages between the various and I'm going to call them health sectors, especially in terms of non-medical care and human health. But as a social scientist, as a sociologist, I'd very much like to get your take on this synergy of strengths where the social scientists are not viewed in the same way as the health scientists, especially in terms of the linkages to what we know is occurring in terms of urbanization, as we showed, but also I would say in terms of climate change. So that the data and the evidence coming out from a variety of other sectors, how do you see that playing into the One Health policy? How can we engage more of the sciences that may not be immediately the assumption of a One Health perspective?
So the question, I'll try to summarize it accurately, but tell me if I didn't. It's with regard to the synergy of strengths in the sociological colleagues, perhaps not being, you didn't say perhaps, not being integrated into the One Health approach and the synergy of strengths in the way that the laboratorians or the clinicians or epidemiologists are, and particularly you ask about climate change. So my answer, I have to give a short one. So first of all, I think we know the position on climate change by the current administration, and that's all I'm going to say about that. But I think it's also clear that even from today's newspaper about the meetings that the current governor of California is bringing together world leaders, but also there's organizations, non-governmental and even governmental, some of whom are in this room, that focus today and have for years and even decades on climate change. For me, it's complex. I wouldn't say complicated, but complex. But for me, the clearest link between climate change and infectious diseases and epidemics is vectors, the range of vectors that transmit. So diseases, whether they're ticks or they're mosquitoes or other vectors, reduvic bugs, tsetse flies. To me, that's really not arguable. I mean, or debatable. That's clear. And so honestly, I think that it's really on us if we don't take appropriate measures for the predictable epidemics. That's why I've been talking about yellow fever for the last 2.5 years. I think that the best proof, although it was best proof of what you said about sociological approach not being integrated, it to me was Ebola in 2014-15 in terms of community engagement or what's called social mobilization and even involvement of anthropologists who had worked in those 3 countries, Liberia, Sierra Leone, and Guinea, prior to the epidemic. They weren't immediately welcomed, and I guess that's speaking euphemistically, but they were needed. And when I worked with MSF, they always do have 1 or 2 anthropologists for the Marburg and Ebola outbreaks, but I'd argue that there's need for even more. It's great what MSF does. WHO does the same thing for those outbreaks involving anthropologists. And I think what's going on now, though, is what we're facing now, what the world is facing now in the Northeast DRC with the Ebola outbreak. It's not what we've ever seen before because of the security issues and because of the community resistance is the phrase that the WHO or the Ministry of Health uses. If we don't stop it very soon and it spreads in 1 or more of the cities, then it gets into the displaced populations. I don't know how it's going to be stopped. So we need to do a whole lot more. And I say anthropological, but sociological, it's more. It's really all of society approach is what's needed. Thank you. Yes, sir.
Yes, I'm Bill Larley. I'd just like to follow up on that. One of the big lessons that we learned in the West Africa Ebola outbreak 2014 to 2016 was that Ebola and for that matter pandemics are much more than a health issue. One of the I've had the privilege throughout my 43-year career to work on different sides of different silos, and we often talk about everyone wants coordination, but no one wants to be coordinated. I've been involved with the One Health movement since the very beginning, and it's hard enough to bring veterinarians, human medicine and ecological or environmental medicine together. One of the things we saw in Ebola is the absence of emergency management expertise being brought into this. Is there a way that we can look in the same way that we need to pull more anthropologists and social sciences, not just human health, but the whole civil society, as you said, approach? Because in the ghettos there at West Point, in West Point ghetto in Monrovia, plain emergency management was the biggest, one of the biggest problems to overcome.
It was, and the president of the country, who someone I admire, the former president of Liberia, President Johnson Sirleaf, did call in the Liberian Army in August of 2014 to this place. It's called the West Point slum in Monrovia, or West Point area of Monrovia, the capital, and she later said that this, it wasn't handled the way that it should have been, and she took responsibility. At least one young man, 16 years old, was shot and died. So I think the question has to do with emergency management, logistics, all of society, civil society, and that's really what's needed. It's very hard to achieve that, particularly in the setting of a contagious infectious disease. And also, in my view, you have people coming in like I did, and others, many others, from a different culture, sometimes of a different skin color, of a different religion, of a different language, although not necessarily, but certainly of different traditions. For example, traditional burials in those three countries, and also in DRC, are different than burials in this country, for the most part. So I think that's really the ultimate synthesis, or the ultimate synergy of strengths that's needed. I do think that, although I've been a strong critic of pretty much everyone, including myself, during the West African Ebola outbreak, including a critic of the World Health Organization, Director General at the time, I do think that the WHO reform effort that occurred, I would say because of, and certainly temporarily right after the Ebola epidemic, has improved their response for the Ebola epidemic last year and for both of them this year. They created a whole another group, and I'll say group because that's not the right word, but group meaning the emergency health program, I think it's called, headed by an Australian physician epidemiologist administrator, Dr. Peter Salama, who I've never met, but I've been very impressed with what with his leadership and with the leadership, frankly, of the new Director General, Dr. Tedros from Ethiopia. I really respect that they've gone to the outbreaks on the ground of Ebola, both of them this year in the DRC, and not just land at the airport in the capital. They went to where the patients are. I think that's the leadership that's needed and that people respect.
Great. One last question, and then I'll encourage everyone to talk to Dr. Lucey after the talk.
So I have a quick comment and a question. So thank you for bringing up those 2 points, very important, anthropological and also breaking down the silos. And as I was intimately involved in the 2014-2016 Ebola domestically, I think I could unfortunately have any anyway. Long story short, USAID AFDA, I don't know how many people were, and I know we have someone from USAID, the Office of Foreign Disaster Assistance. I believe that was the first time the AFDA collaborated with CDC, had agreement, and I think that's something to be encouraged. That's my comment. Anthropologically, AFDA was able to contract with the global communities, where they brought anthropologists to support the global team. And my question is specific to the next epidemic. Why vector-borne disease versus respiratory? Thank you.
So the comment was, if I can paraphrase it, that during the Ebola outbreak in West Africa, there was collaboration working together between USAID, the Office of Foreign Disaster assistance OFTA and the US CDC, and that will hopefully be the case going forward. And I think it has been and will be, and I think it is even now in the outbreak in.
It's been long term.
Yeah,
It's been a long term.
I think it really increased. It became synergistic during 2014, 2015. In the beginning, it was very tough, very tough. I was there 3 weeks in August 2014 in Sierra Leone. It was just a terrible, terrible, terrible situation. There's a real need for operational leadership, is what I call it. But it's even more than just the leadership. But you need leadership to have the coordination that you need. And then your question was about what's next. Why vector-borne disease and not respiratory disease? Yeah. So I'm sorry if I gave the misimpression. So I think that there are multiple things going on at the same time. We haven't recognized them. So I think the right answer is to say pandemic influenza. That's the right answer for our country, to say what's next. And I've been told that. Stop talking about yellow fever. It's pandemic influenza. So for the record, it's pandemic influenza. But there doesn't have to be only one. Nature is, yeah. So it could be respiratory. That's sort of the worst case scenario, pandemic influenza. Although I think that if it was a SARS that continued like it started out in 2003, that might be worse than pandemic influenza of 2009-10, for example. If MERS, which now, as you know, in the past week, now there's a second transmission or second person with MERS from the Middle East who returned home to South Korea. To my knowledge, he hasn't transmitted anybody, unlike 2015 when there was transmission, 186 people and 38 died. But there's other respiratory transmitted diseases all the time, tuberculosis, including drug-resistant tuberculosis, MDR and XDR. There's measles outbreaks all the time, which are highly, both TB and measles, much more highly contagious than the MERS or even than SARS. So I think that there's multiple things going on at the same time. I emphasize yellow fever because for me it's just so predictable, not only that it's going to occur, but what we need to do about it, which is make a lot more vaccine. And that the good news is when vaccination protects you for life. So to me, this is an imperative that it's not just a game of, and you didn't say that, but it's what, it's not just what's next. It's not a game show. It's what's next and what are we going to do about it now to prevent it or mitigate it. And in fact, there's multiple things going on all the time. And there's the Lassa fever, as you know, you don't have to look at ProMed every day to know all these things that are going on. But in some sense, you have to prioritize them. And this thing called the Sept, the coalition, they prioritize 3 diseases to make vaccines. And I try to remember them as L, M, and N. So Lassa, MERS, and Naimah. But there's a lot of others as well. And we need vaccines, we need antivirals, and it's not just about the viruses. The viruses are what are in this exhibit exclusively, but obviously there's a lot of bacterial diseases, parasitic diseases, malaria, and many others that warrant as much or more attention than some of the viruses in the exhibit. And we're very happy, that's the last thing I'll say is, we're very happy that with the do-it-yourself print-on-demand version, you or anyone anywhere in this country or in any country, and I'd say there are countries that it's amazing to me that they've got the DIY version, that they can, like Yemen, like Iraq, like Goma in DRC, it's not Kinshasa, it's Goma, which is the capital of North Kivu province. They've gotten this do-it-yourself version. You can customize the do-it-yourself exhibit to talk about bacteria or parasites or translate it into your own languages, whatever you want to do. It really is a living document. So here I'd like to close, and it's just a couple minutes after 8. Thank you again very much, everyone, for coming out.
All right, thank you so much, everyone, for coming. Just to note, please gather your things. We only have the venue till 8, but I'm sure that Dr. Lucey would like to talk outside. There's plenty of venues here in DuPont. Thanks so much for coming. And just so you're aware, we are going to meet for the fall session the second Wednesday of the month. So it should be the 10th of October will be our next talk, same location. And we'll update the website. And then thank you for everyone providing your information. We'll send out an email reminder with that spreadsheet so you can connect with everyone after the talk, whoever you spoke with. So thanks for coming, guys. It's great to see you and hope you have a good rest of the month. I pinned you in there.
No. You know, not to play on words, but if you say taking 1/5 the dose is immunity for life, provides